Hello, everyone. Welcome to this educational program by the Association of Foreign Correspondents of the USA, AFPC-USA. I'm Patricia Vasconcelos, DC Bureau member of the association, U.S. correspondent for SBT. On this program, addressing the global crisis of maternal mental health. This educational program is in partnership with the Seleni Institute, an independent clinic and nonprofit organization dedicated to transform and destigmatize in maternal and family mental health care. For over a decade, Seleni has been at the forefront of advancing mental health by addressing the unique needs of individuals through all stages of reproductive life. We have three guests with us today. They are already here with us. I'm going to introduce each of you. Ashanda Saint-Jean, she's Chair Obstetrics and Gynecology Health Alliance Hospital of the Hudson Valley, Associate Professor Obstetrics and Gynecology, New York Medical College, Medical Director, Advanced Obstetrics and Gynecology Associates, Westchester Medical Center Health Network. Dr. Saint-Jean is committed to women's health issues, racial disparities, health equity and inclusion, maternal health safety and policies, teen pregnancy, and telemedicine in maternal health. Welcome, Dr. Jean.
Also here with us is Cori Galdo. She's an experienced licensed psychotherapist with over 10 years working with individuals and groups from diverse backgrounds, helping those struggling with a multitude of mental health challenges, including anxiety, depression, anger management, and overall life changes. She uses an individualized integrative approach using scientifically supported techniques from cognitive behavioral therapy, exposure response prevention, acceptance commitment therapy, and mindfulness. After receiving her BS with Magna Cum Laude honors from Santa Clara University, she later earned an MA in Counseling for Mental Health and Wellness from NYU's Stannard School of Culture, Education, and Human Development. She's a member of the Academic Honor Society Phi Beta Kappa. Cori has received specialized training at the Beck Institute for Cognitive Behavior Therapy, the Albert Ellis Institute, and the Association for Contextual Behavioral Sciences. She also completed further education in PMADs, grief, loss, and fertility-related distress at Seleni to later train hundreds of therapists on behalf of the Institute in perinatal mood and anxiety disorders in Colombia and Panama.
Outside of her practice, Cori has continued to be involved in philanthropic work by assisting the psychology department at Kenya, a center for malnourished kids and adolescent mothers in her hometown of Venezuela.
Also here with us, Lavinia Lumu. Welcome. Psychiatrist, private practice, president-elected International Marseille Society for Perinatal Mental Health, Honorary Lecturer, Department of Psychiatry, University of the Witwatersrand. An advocate at heart, Dr. Lumu's dedication extends beyond her clinical practice. She fervently champions maternal mental health initiatives and is committed to transformative change in the realm of perinatal psychiatry.
Before we start with the first question, and it's a question that I would address to each of you individually, we have some statistics here to share with our audience in order to inform them. Maternal mental health conditions are one of the most common complications during pregnancy, right, and postpartum period. Just to give an example, 1 in 5 women will experience a mental health condition during pregnancy or the first postnatal year here in the United States. 1 in 4 women will experience a mental health condition during pregnancy of the first postnatal year in low and middle income countries. So maternal mental health conditions are among the most common complications of pregnancy and childbirth, yet they are often underdiagnosed or an untreated. So can each of you briefly describe your work in this field and share why addressing this issue, maternal mental health, is a priority? Ashanda, if you would like to start.
Thank you so much for the question, and thank you for the opportunity to truly uplift maternal mental health, because we are in crisis here in the United States. As we have learned recently, maternal mental health is now the leading cause of maternal mortality. So I think there's a collection of reasons why. Number one, this is kind of front page news here in the United States, but also there's complexities to terms of how we deal with it and how we address access and coverage for patients. So first and foremost, we have to talk about screening, right? We want to screen our patients probably pre-gestationally, so before they get pregnant, but also during their prenatal course. And there is a lot of stigma, fear, shame that is involved. You have patients who already have pre-existing psychiatric or mental health conditions who don't want to disclose that, or fear that coming off of their medication may impact their pregnancy, or come off of it without discussing it with their mental health specialist. So that's one kind of caveat to what's happening. In addition is screening. So the screening tools that we use prenatally are the Edinburgh Depression Scale, or we use the PHQ-2 or the PHQ-9. However, those two tools don't adequately test for anxiety. So we know the most common causes of mental health conditions during the prenatal course and postpartum course are both depression and anxiety. And often anxiety gets left out. We don't talk enough about that, and those impact our patients so much. In addition to that, then it's the organization of treatment. So once we screen for it and they screen positive, how do we provide linkages to care? That's our gap that we have. So we are under-resourced in the United States. There are not enough mental health providers. There's a new actual category called reproductive psychiatry, which is incredible. These are people who specialize in birthing people, pregnant people. And so we want to make sure that they get those specialized skills that could really help them, and also tailored to the pregnancy so that they know that there are medications that are safe to take in pregnancy. I think also the last thing I'll say before my colleagues jump in is we have to address cultural continuity and congruency. So a patient can come and they can say, well, I'm having a bad day, right? Or often what happens with our Black Americans in the United States, they culturally call postpartum depression postpartum. And so I've had instances where I've had students say, the patient's not really concerned with anything. She just keeps saying she has postpartum. And they think that, yeah, well, I just told her she's in her postpartum period. Well, no, she's trying to tell you she's going through postpartum depression. So there is a level of cultural concordance that must happen when we relate to our patients. And then I think lastly, I'm just going to say there's always the fear that revealing those information, right? Revealing that they may not be well, that it may be weaponized against them, or their child may be taken away from them, or they may not be a good mother. And so there is so many layers to what happens in terms of what our patients face. And so we need to truly uplift what mental health is. We need to normalize screening and access to care. And this, I think, we can truly kind of address and combat what's happening now in the United States with mental health conditions being the primary cause for maternal mortality.
Correspondents would like to add any comments and answer why we face this reality.
Yes, and I thank you, as Dr. Saint-Jean said, and I'd like to give you the perspective from a clinical mental health practitioner like myself, because the audience, it's important for them to know that maternal mental health is influenced by biopsychosocial factors. And I, as a therapist, focus more heavily on the psychological aspects of things by providing support via psychotherapy to women or to people in their perinatal phase. And I always like to stress the word perinatal, because most of the conversation and awareness is around the postpartum phase, but we understand the perinatal, meaning before, so from conception, during, and after pregnancy. And when I say after, it's a full year after pregnancy, not just the weeks immediately following, to be the time frame in which these issues arise. And then when we're talking about perinatal mental health, I also like to explain to people that there is a range of distress. We can look at it and think about it as a continuum. On one end of the continuum, on this end, let's call the most severe, as those deaths by despairs and statistics that you've mentioned, right? And psychiatric emergencies and things of that sort. But there's an entire range of people that are struggling with maternal mental health. And it can be from the 80% of birthing parents that comment on having what we call baby blues. That is something that it's very hormonal, that it after 2 or 3 weeks, they seem to resolve on their own. And then we go towards, let's say, about 20% of at least the women I see in my clinical practice that don't even fully meet criteria for a diagnosis of a perinatal mood and anxiety disorder, but that are really, really struggling and actually need a lot of support to hopefully don't meet criteria eventually. And then we go to the PMADs. PMADs, it's a term I hope most of us start hearing a lot, which is perinatal mood and anxiety disorders. And that's that 1 in 5 statistic you mentioned in developed countries, and even 1 in 4 in underdeveloped countries. So as a clinical psychotherapist, I see, well, there's many ways, but I see 2 ways in which primarily I attend to the population. In the clinical practice, and I always start with an intervention that might seem very simple, but that is very powerful, which is psychoeducation. It's providing accurate information that tells these people, this that you're experiencing, it's real. There's a word for it. There's a field dedicated to it, and hopefully there's treatment for it. And this approach of psychoeducation, I've also seen it work even in the foundational work I do in Caracas, Venezuela. It's like when you give a name and an explanation, of course, in a culturally sensitive way, it can go very far. And the last thing that I'll say is that we do a lot at the Seleni Institute is training others, is expanding the network of professionals, not just mental health, not just healthcare, but professionals around the world and across specializations, training them for them to understand what PMADs and what mental health is and what can be done. Because ultimately what we're all trying to do here is raise awareness, create prevention, and give treatment.
Mm-hmm. Lavinia, so now if you could describe your work in this field and share your thoughts on why maternal mental health is a priority.
Thank you, Patricia. Thank you for this opportunity to discuss a very, very important topic. So essentially, we need to be aware of the fact that pregnancy is a very vulnerable time in any woman's life. It's already a biologically very stressful event. And what has been happening is for too long, mental illnesses or psychiatric conditions have been sidelined. People don't believe that mental illness is real. People think that it doesn't exist, and obviously it's an experience. It's one of those conditions or illnesses that a person experiences. And what happens during pregnancy is with the surge and changes hormonally, it then causes underlying untreated mental illnesses to unravel. and come to the fore. And this is why women at this particular point are particularly vulnerable to presenting with various mental conditions. And we are also in an era where in the past, people thought that, well, she's on medication for depression, let's stop her medication, and, you know, because it's dangerous. And partly that's based on stigma. And stigma becomes a barrier to accessing healthcare. And we are in an era where we've done a lot of research, and we've demonstrated that psychiatric medication is actually potentially safe for not only breastfeeding, but pregnancy as well. And that we need to manage depression and anxiety and psychiatric conditions during pregnancy, just like we do for other medical conditions like depression and anxiety. And also, for too long, we've watched women suffer through pregnancy. As a psychiatrist, often what we see is the worst outcome, which is mothers presenting with severe depression during pregnancy, suicidality during pregnancy, psychosis during pregnancy. These are all extreme outcomes. And at delivery, it has been proven that untreated mental illness actually makes delivery more complicated, more difficult. It interferes with bonding with the baby in the postpartum. And I'm from South Africa, and in South Africa, and as is the case in most countries on the continent, we are mostly low and middle income countries. Our rates of peripartum depression and anxiety are as high as 1 in 3. And what we then see are the really bad outcomes, which is increase in maternal suicides and infanticide, where mothers in the state of desperation, knowing that they can't care for their baby, end up thinking that killing themselves and the baby would be the best outcome. So we want to create a new movement whereby mental illness, mental health is given the same attention as all the other medical conditions, especially during this vulnerable time that mothers go through. So yeah, that's all I have to say for now. Thank you.
As you mentioned, suicide is a leading cause of maternal mortality worldwide, accounting for an estimated 20% of death during pregnancy and the first postnatal year. Lavinia, if you could take the lead for the second questions, would be to understand the problem. So in your opinion, what would be the most significant maternal mental health issues you've encountered in your practice? And are there specific challenges you see that are unique to different regions or populations, especially in low resources, underserved areas?
All right. So in low and middle income countries, the biggest problem we do have is a lack of mental health professionals. We don't have enough mental health professionals. So even if we pick up mental illnesses during this period, and it's a very specialized period, because as Dr. Saint-Jean has mentioned, you need to be specialized in terms of what medications are safe during this time. So the first challenge is we don't have enough mental health professionals. And secondly, in our setting, stigma is a huge problem. People are afraid to be diagnosed with a mental illness. They fear that their children will be taken away. There are also some specific cultural issues that we are faced with, where people may believe culturally that having a mental illness is associated with some form of spiritual attack or bewitchment. But also what we are faced with in our setting is people from poor socioeconomic backgrounds, poverty, uneducated women, and we also have a huge problem of teenage pregnancy, substance use during pregnancy. And this is the complexity of mental illnesses. All of these things sort of group together and present, and then the woman is then pregnant, and then it increases her risk of developing a mental illness greatly so. So what, in summary, just to say that it's a lot of psychosocial factors that also increase the risk of developing mental illness in this very vulnerable period, that is the peripartum period.
Dr. Saint-Jean, if you could also answer what are the most significant maternal health issues you've encountered in your practice, and if you can describe some specific challenges you see that are different according to regions or populations.
Absolutely. I would say the majority of my career was in New York City, where, we have a high concentration of medical professionals, right? And so we have access to mental health specialists and reproductive psychiatrists and social workers and caseworkers. And we have all of these partnerships with community services and community-based organizations. And so, once we were able to identify someone, right? And if they felt that that bridge of trust was already developed and they could truly share and they could answer everything honestly, we were able to really kind of link them to care. And I now can realize it was more effortless. I have since the pandemic moved upstate to kind of a rural area in New York State. And what I have seen there is completely and utterly different from the city. So we have a large prevalence of substance use disorder. And what we do not have is collaborative care models where we are working in partnership with our mental health specialists to really provide access to these patients. And so what happens is that there are no linkages. And so getting patients on Suboxone or those things, I have a lot of, doctors or professionals who say, well, I don't feel comfortable putting someone on that, or I don't feel comfortable putting a pregnant person on that. And so our professionals are not even doing the education to know what is safe in pregnancy or not. So, you have these kind of like dead ends for patients. And I'll tell you, I had a patient one time and she went all the way up to 28 weeks and finally told me, she goes, Doc, I've been using my friend Subutex and now she won't give it to me anymore. And I'm so afraid that I'm going to start using during this pregnancy. And so with that, first, I acknowledged her bravery and thanked her for trusting me. And then I was able to, through a collaborative care model, get her a linkage so that we can get her on her own Subutex. So these are kind of, when you think of the concentrations of populations in the United States, there's rural and there's urban, and there are what we call medical deserts, where we do not have providers. One of the things that we learned through the pandemic is the usage of the virtual platform. But I think what the caveat we don't talk about is some providers do not accept insurances. They may only want cash only payments. Patients may be on what we use in the United States, Medicaid. So these are, kind of barriers to care. I think one of the things that we haven't talked about is what we categorize as social determinants of health. And these are non-medical conditions that impact outcomes. And one of those is language barriers. Then we also have to then be kind of tailor that link to a mental health specialist who speaks the same language. And what I found upstate New York is we have a large population of people from Guatemala who don't speak Spanish. And I speak Spanish, but they speak indigenous languages. So we have language as a barrier, and then we have healthcare literacy. So if I tell you what to do and you don't really understand, or I'm not putting it on a level that you understand, or if I print out instructions and you can't read, then how are you gonna fulfill what you need to do? So we have to think of, unstable housing, homelessness, education, lack of insurance, language. These are all barriers to care. And what we're seeing is now is that one of the things we did in New York State is we have extended Medicaid for a complete year after pregnancy. So it's no longer just the 6 weeks, it's a whole year, because what we found is over 75% of maternal mortality happens after that 43 days. And so these patients still need insurance so that they can get the care that they so rightly deserve. And I think one of the other things I want to say lastly is that often our patients struggle with wanting to be a good mother, and the fear of disclosing that they're struggling, even though it's something that it's not of their, it's the hormones that are going through. Just like when we have patients who are going through baby blues 3 or 4 days after delivery, we have to reassure them that this is not of their doing. Their hormones have changed. And so there's a fear of failing as a mother. There's so much stress, and this could be society, but also within their family structure, to be that perfect mother, to be that great mother, to get everything done, to not be afraid that I'm tired or telling someone I'm tired or I need help. And so I think what we struggle with in this society is normalizing being forthright and really trusting your provider. We're supposed to be trusted messengers, right? We're supposed to be there to, as our Hippocratic Oath says, first do no harm. We're there to help you. And so one of the things I always start with when a patient discloses something so personal is thank you for your bravery. Thank you for trusting me. Now let's see how we can get you help.
Corrigaldo, have you experienced any of those challenges while working, and any specific challenge, something different you'd like to add?
Yes, I mean, I think it's a great piggybacking on what both Dr. Saint-Jean and Dr. Lumu have said. But I'd like to share with the audience and with everyone an observation that I've made from working in New York City, right, in a kind of a clinical practice at the Seleni Institute, but also in hearing the many stories of women in my hometown of Caracas. And while I want to start by recognizing that these two groups live vastly different lives, I do see that there is one common struggle I noticed across the population, and that is the discrepancy between the expectation and their reality when it comes to their perinatal experience, or most specifically the postpartum phase. And what I mean by this is that we all know that the narrative around motherhood is extremely romanticized, how Dr. Saint-Jean was explaining. It is expected that it's a time full of joy, idyllic, many of the stories and images we've all seen. And while this is possible and can be the experience for some, for many others, it's quite different. And I see the struggle arising in this discrepancy when I hear so many of them say, wait, I didn't know this was going to be this way. How come no one mentioned it? I have moms, aunts, friends, and why did no one say this? And in that, I would say that if you ask me in my practice, that is the most common struggle I see. And however it presents varies culturally and socioeconomically and all those things, but it's a common struggle. And when this starts being more than a struggle, but a issue and a concern, I see it manifested mostly in intrusive thoughts. Now, the audience should know that intrusive thoughts are the hallmark of the perinatal mood and anxiety disorders. They're present in all of them. And intrusive thoughts are these scary, repetitive thoughts that many birthing parents are experiencing, and that they don't like them. They don't know why they're happening. They're many times afraid to share. What kind of mother would be thinking this? How is it possible that it's even going through my mind? And here is where I go back to the power of psychoeducation. Sometimes by simply explaining to them, listen, when you have these thoughts that you don't like, that are distressing, in psych terms, we call them ego dystonic. We don't want them, we want them far. And that is, they're ego dystonic. If anything, there's a protective instinct in the fact that you experience them as distressing. For example, that's one of the examples. When we explain that intrusive thoughts do not make them bad, that there's nothing wrong with them, but this is part of the experience and the distress, I find it extremely, extremely important. You mentioned a specific issue for a specific population. And there's this concept, I'm from Venezuela, so I'm part of the Latinx community, and I understand that that's a huge amount of us that fit that group. But in the Latin culture, there is this ideal of mothers being that madre abnegada, that self-sacrificing mom. Many coined the term Marianismo, right? Which is related to the Virgin Mary and the Catholic religion in any regards. There is this expectation that the good mother is the mother that puts everyone, especially their kids, but every member of their family before them. So if we take into consideration this cultural variable, we could understand why so many really struggle in asking for help, accepting help, confessing they need help, or even, putting themselves in the center of the conversation. So yeah, there's many other things I think we could all talk about, but that is the most prevalent I see.
Mm-hmm. And let's stay with you, Corey, if you could also explain for us, from your perspective, why do you believe that the most significant barriers to accessing care? How can we reduce or eliminate obstacles if we see that one of the largest obstacles is that less than 15% of women that are experiencing those mental health conditions, maternal mental health conditions, they actually receive treatment?
Yes, you're speaking to that huge gap that exists between how many are struggling with these issues and how many are receiving.
Why this perspective?
Yeah, so I can't help but explain this from an individual level and also from a systemic level, right? We need to start by acknowledging that the childbearing experience and the postpartum phase is extremely hectic, to say the least, and the entire perinatal phase, but especially, that postpartum phase. And let's imagine someone who just gave birth, right? Their partner is probably back at work because no paid leave, right? And she is on her own dealing with a newborn and with everything that exists surrounding those responsibilities. Many times it's just, and I see that when they eventually get to our practice, many times it's just a matter of, I didn't even notice all of this was happening. I didn't have the time or the energy to, ask for help. And it's important to say this up front. It's not that women aren't raising their voices, is that often they can't because there's simply no time. And then I would stress the matter again of stigma. Too many times I've heard them say, I can't believe I'm saying this. What if someone knows? Can my baby be taken away? Will I be put away? There's fear and guilt and shame around this experience, a little bit of what I was saying before, this experience not following what a lot and everyone had mentioned. So stigma is very, very, very important. And then lastly, to go a little bit back to what Dr. Saint-Jean mentioned about screening, right? We know, especially in the US, that in their pregnancy, these people have a lot, and even in the postpartum, have a lot of contact with healthcare providers, whether it's their OBGYN, nurse, doula, then the pediatrician. There's a lot of points of contacts in which I think there's been good efforts and progress in screening. The thing is that the majority of these points of contacts end by 6 months if you're lucky, right? And then there's the gap between that 6 months to the year or even after a year, in which and where we observe kind of a peak in the crisis and suicidality and depression and all these things that can happen. So in an ideal world, right, in which we can all hope for and work for, if we attend at an individual level by keep having these conversations, continuing to have conversations that help to work around the stigma that we all have mentioned. And then if we include more screenings, not just what to ask, but how to ask it. Because I'll finish after this. I have a lot of, people that I've met and that have come to me that even we are a clinical practice, that I go through the screening, the PHQ-9 or whatever, and sometimes they were like, no, it's okay. I didn't have time to answer that, or I'm not sure if I should answer that. And I recognize that in a conversation, once the trust is and the rapport has been set, they do answer everything that we were asking, but they required the interaction and the not faith is not the word that I'm looking for, the trust to say it, right? And I understand that not everyone has, like I do in my practice, 45 minutes with each patient, yet I really do think that we are close in knowing what to ask, but there's a lot of work in getting to how to ask it.
Thank you. Dr. Lomo, what are your thoughts on the main barriers and having access to the treatment, and your thoughts and how to improve this reality?
All right, so there are specific things that occur in most low and middle income countries. Whereas, if we look at an antenatal clinic setting, in our country, for example, in South Africa, it will be one midwife having to screen 50 pregnant women per day. And obviously, given that there's a lot of questions that need to be asked, so what they do is they avoid asking the screening questions related to mental health. And if we look at the screening tools available, I mean, the Edinburgh Postnatal Depression Scale is internationally, validated for use. But in our setting in South Africa, we have 11 official languages. And it is quite a difficult scale to use and translate into the different languages. So we formulated our own screening tool that can be translated into most languages. And it's just 3 questions. So what we found very interesting is, even though those 3 questions have been incorporated into the screening that's supposed to happen at the antenatal clinic, these questions are not being asked because, well, if a healthcare professional picks up an issue, refer to who? So that's the biggest challenge is mental health services are only available in large centers. Women can't access these services. Stigma as well plays a role because everyone knows, that's the psychiatric hospital, the mental health hospital. So they don't go. We also have challenges of healthcare professionals discouraging patients from taking medication, a psychiatric medication, so they stop their medication as well. So these are some of the barriers that we are faced with. So I'm at a point where because there'll never be enough mental health practitioners. So one needs to move away from focusing on just that they're not being enough to maybe just trying other strategies. We need to work more collaboratively, because what happens is everything is isolated. You have the obstetrician, you have the midwife, you have the pediatrician. Everyone forgets about the psychiatrist and the psychologist. So to work together and provide more global maternal health care. What we're trying to do is try and empower and educate healthcare professionals so that they ask the questions. One of my colleagues did research at one of our clinics in South Africa, Johannesburg clinic, very busy clinic, and they found that pregnant women in the whole, just being asked, how are you? Just to check in was enough for them to feel heard, and it creates the platform for them to speak up. So creating more of that and looking at other strategies, more group-based strategies of intervention, and then screening early, and the ones who are really ill getting referred quickly so that we prevent and decrease mortality and morbidity of mothers. And also, let's not forget about what happens to the child that is born, especially in instances where mom's unwell. In South Africa, there's high rates of moms dumping their babies because they're not able to look after them. And also, we don't do as much research, but infanticide is definitely something that is a really bad consequence of neglected mental health care during this period. So I think those are the main things to focus on, is to spread the word, educate, break down stigma, and encourage people to be more open about this very important condition. I often say that, and I learned it in the pandemic, that mental health or mental illness is a forgotten pandemic that we need to pay attention to.
A forgotten pandemic. Ashanda, do you share those thoughts as well? What are the main barriers you face while working in your thoughts on how improving this reality?
Yeah, I mean, I think my colleagues have put it so eloquently about the struggles that we all face, even though we're in all different places in the world, right? And one of the things that I did when I moved upstate and becoming the chair of the department, I had a little bit of power, right? And so I was able to kind of go back to the bedrock, to the foundation, and kind of look at it through a patient-centered approach where we elevate the patient, right? And that way we develop programming around the patient. And so one of the first things I did was we started to do depression screening before patients are discharged from the hospital, right? Now, again, we all know that sometimes those screenings are not actually accurate so quickly, because if you had a vaginal delivery in the United States, you're typically discharged on day 2 after delivery. If you had a C-section, you're typically discharged on day 3 or 4. And so we know that baby blues and other kind of manifestations of depression or anxiety may kind of come in afterwards, right? And so, but we still wanted to see if we could identify folks before they leave the hospital. So we did that. And we had to develop a escalation algorithm, right? So if they test positive, then what do we do, right? Because we can't have a screening tool and then we have no treatment if we get the positive result. So we were able to work with, again, looking at that collaborative care model, right? Working with our mental health colleagues and developing an escalation pathway that our nurses can trigger or our providers can trigger to then really kind of create kind of a unification of patients with mental health specialists. So that was one thing we did. The next thing we did was typically we, in the American College of Obstetrics and Gynecology, often talks about the forgotten trimester, which is the 4th trimester, which is after the baby is born, right? We just say, oh, we see them in 6 weeks and okay, good luck, goodbye, see you later, right? But what we did was we said, you know what, let's see those patients in a week. So all of our patients, whether they're a vaginal delivery or a C-section, they all get what we call a postpartum wellness visit in a week. And what we do, there's 4 pillars to that visit, and that visit can be done either virtually or in person. And the 4 pillars are: 1, we repeat the depression screening and we compare the results. Number 2 is that we do lactation support. So are you breastfeeding? Do you need help? Do you need a consultation? 3, we do blood pressure monitoring, because we know maternal mortality for Black women, our highest rate is cardiovascular disease. And so we want to make sure that we put in that blood pressure monitoring. And if this is a person who's not able to come in person, we then prescribe them a blood pressure monitor, so they go home with that. Or if they were in the hospital for any hypertensive disease in pregnancy. And then lastly, wound care. So again, we know that, if they had an incision, we look at the wound. So that's kind of instituting that postpartum wellness visit, right? And then that is in addition to their 6-week visit. But I think that when we kind of look through a lens, right? And so it's kind of like, if we had all the ideal funding and all the possibilities, what will we do? Well, number 1, I would say we would normalize help. Normalize talking about your mental illness. Do not say, how are you doing? And expect the person to say, fine. No, tell me how you're feeling, right? And normalize saying, fine is not an answer. Tell me how you're doing. I think also we have to elevate what my colleagues have said, the trials and tribulations of a new mother, right? And what sleep deprivation can do. And that on top of any chronic illnesses or even mental health, conditions that a patient may have. Remember, when someone has a C-section, they're going through the recovery of major abdominal surgery, then taking care of a child, maybe breastfeeding, then making sure that they're doing all the super mother things that they need to do. So it is, I apologize for the background, I'm in New York City. This is New York. But what I will say is we can kind of be aspirational in terms of what we can do. We are talking a lot about doulas, right? Having doulas work postpartum. We need to talk about, we've elevated the virtual platform for mental health visits. What about at-home visits, right? We have visiting nursing programs in the United States. What about visiting mental health programs? What about mental health mobile units? What about community health workers? How do we optimize support for those who are in the highest need of support? We have the statistics. We know what suicide does. We know that mental health causes more maternal mortality. We know the impact on postpartum psychosis and infanticide, right? Why are we not doing anything? We want the funding to be had to prioritize all of these families, these communities, so that people are freed in terms of care and access for mental health conditions. And so those are my aspirational desires. I think we're all in this struggle together, working hard to really kind of put a lens and a focus on what is needed across the world. And that's why I'm so honored to be here with my colleagues, because we all are having the same challenges all over the world, right? And so this is how we can kind of learn from each other, be collaborative care models globally to bring forth awareness and development of program that will help families and pregnant people.
Mm-hmm. And Dr. Lumo, if we can talk a bit about the impact of untreated mental health conditions. We all know that untreated maternal mental health issues can have long-term impacts on children, on families, communities. Could you discuss with us the broader societal, economic, or development consequences of leaving those issues unaddressed if we do not treat them?
I think that's a very important question. Untreated mental illness will result in, if we look at the pregnancy itself, it will make the pregnancy more difficult. Delivery will be more difficult. It increases the risk of complicated delivery. And also, untreated mental illness for the mother will mean that follow-up with her antenatal care, going her visits, is lower. Nutritionally, she may not take care of herself. increases the risk of the use of substances during pregnancy as well. So that's just during pregnancy and then the delivery period. The impact on the fetus or the growing fetus will mean that untreated mental illness causes release of more stress hormones, which will interfere with the growth of the fetus. So what then happens is it also increases the risk of, in the postpartum, for the baby, higher rates of a neonatal ICU admission and more complications for the mother. And if we now go into the postpartum, the untreated mental illness, particularly for psychiatric illnesses, there's an increased risk of bipolar disorder. Often for women, bipolar disorder has its first presentation in the postpartum period. So this is a very critical period because your pregnancy hormones that were high during pregnancy all of a sudden drop. And that sudden dip opens the door for all these, the underlying mental illness to come up. So we have an increased risk of postpartum psychosis, postpartum depression, and mania. We really are concerned about those periods because for psychiatry, that means the mother has to be admitted, sometimes against her will, to receive care. She's separated from the baby. She could try and kill herself, try and kill the baby. So that's just focusing on that. If we look at what happens to the baby afterwards, even if, let's say, she goes home and she's sort of disconnected from the baby, child neglect can happen. It can interfere with attachment of the baby. And then that in itself will increase the risk for that baby to going on to developing mental health issues later on. So that's just, in summary, the outcomes that would happen if we elected not to treat mental illness. So all in all, untreated mental illness will result in poor outcomes for obstetrically for the mother and poor outcomes for the baby. So we need to pay more attention to it because there are increased rates of morbidity and mortality for both mother and baby.
Dr. Saint-Jean, any other thought here or problems you would like to add in the same issue if those problems are not treated in time?
So I posed the question, if someone had diabetes, would we not treat it? If someone had hypertension, would we not treat it? If someone had cardiac illness, would we not treat it? So why are we not treating? Why are we not prioritizing mental health? And especially in our most vulnerable population, which is, our pregnant patients and motherhood. I went into OB because I thought I would be part of the best day of someone's life. And I really didn't think that people died having babies, right? I never thought that there were bad outcomes. And I think this goes back to what my colleague said about, perception and reality, right? The reality is that these conditions and these thoughts and these processes happen, right? And so there has to be a way that we prioritize this, and this should be number one priority. And in the United States, again, maternal mental health conditions are the primary cause of maternal mortality, right? And I say this again and again because I just want it to be heard. This is a public health crisis for us. And so if we treat other illnesses, why do we not treat this? Why do we not see this as most important, especially given the statistics? And we want people to enter the journey of motherhood and pregnancy, one that should be filled with joy and happiness. And unfortunately, they're not able to kind of capture that joy, right? Again, when you're recovering from a vaginal birth and you may have anemia and you're weak and you're up all night and you're breastfeeding, you have sore nipples. I mean, there's so many things that go along with that. And so we are not allowing our patients to feel the joy that they so rightly deserve. So why are we not treating this? Why is this not a priority when we treat so many other illnesses?
And if we think on current solutions and initiatives, Corey, do you believe that there are specific models or strategies that you believe that could be scaled to other countries or regions? And what initiatives, policies are currently making the most impact in addressing maternal mental health conditions in your field of work?
Yes, so I want us to stay with Dr. Saint-Jean's image of this mother and this period where she's breastfeeding maybe or feeding late at night, one of those sleepless nights, right? In which one thinks, I'm the only person awake. No one is as tired as I am. You know, I am alone in the world. And in those moments, for whatever reason, maybe there's not a partner home, or maybe they have to wake up early and not waking them up, no one's around. I find that the maternal mental health hotline, national hotline that has been now running and initiatives like such are invaluable. Us therapists, we don't take 24/7 calls. And so for a mother who is in that state at 3 a.m., being able to pick up the phone and call a hotline and know that someone who is trained, right, in Spanish and in English, but also there's translators that can just be with them for 20 minutes or 2 hours and help them ride the wave that they might be drowning in the moment. Initiatives like that from a psychotherapist standpoint, I think are invaluable. And I understand the effort and resources are behind them, yet they seem to be replicable in an era of technology. Now, when again, my home country of Venezuela, there is zero data on maternal mental health. Zero might be an exaggeration, but close to it. And in this moment, in this crisis that we are, most initiatives are privately funded and through NGOs, and most of them attend, like the one I collaborate with, most of them attend basic needs of food and shelter, right? If you think of the pyramid of needs, because there's so much needs, we're attending those. Yet anecdotally, we've observed that when you can piggyback on one of these initiatives, let's say lactation, which is nutrition and food security is a big thing of what's when you can piggyback and add 1 or 2 moments of contact with the moms that are there to give their kids food, or with the moms that are there to understand how to feed them in the situation that they're in, you can go a long way just by asking 1 or 2. It's not ideal, but it's a first step. In initiatives that are already there, maybe for a different topic, for example, faith-based interventions, in countries like Venezuela, faith leaders play an important role in the community. And if any little piece of the psychoeducation of maternal mental health can be added, I think it's a first step that gives me hope, even in the most dire of circumstances.
Dr. Lomo, any other example you would like to share with us that you experienced or you believe it's working? Your thoughts?
So what we're trying to do in South Africa is try to incorporate mental health services into the antenatal services. So we are starting to introduce the concept that while the mother comes for her checkup, which is typically every 4 weeks from 20 weeks, while they see the obstetrician, doctor, and the midwife, then they can also see a mental health practitioner. It's slow to start, but what I'm learning is that perinatal mental health, it's a team effort. it can't just be the midwife's problem or the social worker's problem or the obstetrician's problem. It requires all of us working together collaboratively. And I think that's our goal, to try and introduce that. Because once we get that, then we break down stigma and it's accessible to everyone. So yeah, those are some of the initiatives that we want to look at, and to try and look at more group interventions, because we have a lot of patients in a country not far from us, Zimbabwe, our neighbor. They have the Friendship Bench initiative. So moms would come to the antenatal clinic, and then there's a bench where a mother who's delivered, an older woman, would sit there. And if someone's having a little bit of difficulty while they're waiting, they go sit on that bench and they sort of share their experiences of motherhood and what they're struggling with. And it's a form of psychotherapy, if you think about it. In South Africa, we've got community health workers, and we are trying to upskill through our nonprofit organizations. There's a foundation I support called the Flourish Foundation, where there are mothers in the community who start up groups where they support other mothers, and I teach them how to screen for mental conditions and refer. So it's all little bits and pieces, but I think the exchange is really fascinating, that no matter where we are in the world, we all want one thing. Happy mom equals happy baby, equals happy nation, equals flourishing nations, equals improved GDPs worldwide. Yeah, so that's what we want to work towards.
Mm-hmm. Dr. Saint-Jean, your thoughts on the strategies that you've experienced or you believe that also can be used in other countries and other regions?
I want to steal her. I love the bench. I think that's incredible. Oh my gosh, that's genius.
Hotline is something as well that many countries could adopt, right?
Yeah, I mean, and it's a small effort, but it's massive, right? Massive. It has a massive net. But one of the things we do, again, is we do maternal medical home. And so what we do is that we organize a collection of all of our specialists, which is our obstetricians, our midwives, our doulas, our community health workers, our mental health specialists, our social workers, and we go through every pregnant patient. And one of the interesting things that we do is we include our receptionist, right? And because she could tell us what's happening in the waiting room that we may not see, right? And then we include, our nurse, and because they may have an interaction with the nurse before the provider comes in. And so one of the things is we kind of use that kind of multidisciplinary approach to kind of organize and customize care plans for each patient. So we're able to do that for all of our OB patients. In addition to that, we do have centering in pregnancy, and that's something that kind of went by the wayside during COVID, but it's group prenatal care where we organize groups based on their gestational age. And that way, participants are able to develop a camaraderie with other pregnant people around the same gestational age, and they're able to talk about what's going on because guess what? They have a peer, right? And, we have support groups as well, but sometimes the centering group becomes the support group. And so, you may say, I'm having nausea and vomiting, or I'm having these thoughts, and another one, I'm having them too. And then they kind of then have that kind of group therapy together. I think also the incorporations of doula into obstetric care teams is so important, and kind of the advancement of having reproductive mental health specialists who focus on this. I think that we don't do enough for our patients who are entering the pregnancy journey. And so these are people who are attempting to conceive or may struggle with infertility, as well as talking more about the postpartum patients. But I think that, there are strategies that we can all collaborate with. And I think, lastly, one of the things I wanted to say, and I'm sorry I forgot, was that we often have providers who are hesitant to prescribe psychiatric medications. So there's a lot of obstetricians, I don't feel comfortable, I don't have enough understanding. And so what we're doing a lot in the United States is, again, having that collaborative care model. It's almost like a triangle where the patient will see the specialist, they will recommend what medication the patient should be on, and the obstetrician or the family medicine doctor, they will prescribe it. And so kind of we're working in concert with each other, because again, if we look at it from a patient-centered approach, the patient is at the center and the patient is the most important thing or person, right? The most important person that we need to care for. So I'm just very excited about what's happening in Zimbabwe and South Africa. That's incredible. I want to create a bench everywhere. So, wow, thank you for sharing that.
So now we are almost reaching the end of our educational program. I have a last question for each of you. If we look into innovations and future directions, Corey, looking ahead, what is, from your perspective, the most urgent action needed right now to better support maternal mental health? What can individual or organizations do actually to make a tangible impact?
I think continuing with the conversation of interdisciplinary, right? And all of us coming together, and from wherever you are working, expand and the network. Like at Seleni, we do trainings in person, via web, expanding the network. And I'm excited to see more of us in the field. From all over, women, all of us coming together and being more present in the field, because we have more of an impact where we are. And me dreaming again of how technology can help us. One of the things that I work so much with my patients is limiting where they get information from. So again, the mom at 3 a.m. burping the baby. I have a scary thought. I go online, I search, and wow, what she can find in that moment. Some of it is very valuable. Some of it is very dangerous, actually, because of the misinformation. So if AI or some technology could help us to really curate and fact check that information that is out there for the person who is desperately hanging on to anything that they read online, I think that would help us, them, but all of us, a lot.
And Dr. Lomo, your thoughts on the same question from your perspective. What do you believe individuals and organizations can actually do to make a real impact?
I think Corey has touched on something very important, which is education, changing our curricula, in terms of medical training and health training. Also, in South Africa, the budget, the health budget, the amount of money that mental health gets is very small. So that's another reason we don't have enough mental health services. So to mobilize and change policy so that we get a larger budget. Also, what's happening on the ground is a lot of research is being done in low and middle income countries in this space. And the issue we have is it's not published. It's not published, it's not on global platforms. And I'd like that to be reformed, because what is happening is what happens in high income countries then gets funneled and channeled through to low and middle income countries. And things are similar, but they're also very, very different, because research is the key to also influencing policy change and how we create pathways of care in this space.
Thank you. And Dr. Saint-Jean, your thoughts on this matter?
I think we need to develop more pipeline programs for mental health specialists. I think there needs to be funding. I think there needs to be recruitment. I think we have to start, if we keep saying that there's a deficit of mental health specialists, then we need more, right? And so we have to then look at, you know, how we can attract more people into the field, you know, create programming that is attainable. And I think that this should be part of kind of a profession that is kind of advertised and desired, and developing pathways that people can access to it, right? I mean, I think people are sometimes unsure, like our students are unsure, how do I become a mental health specialist? How does that happen? And I think that we have to develop more pipeline programming so that we have more specialists, so that patients can get the thing. One of the things we talk about, a barrier to care, is access, right? Well, again, we need more resources, we need more specialists. And so I hope that recognizing the impact of mental health on the pregnancy journey will kind of get the development of those programming happening.
Would like to thank each of you, and I would like to give the opportunity to each of you to add any thought for, you know, for the conclusion of this important educational program focused on foreign journalists that are based here in the US. Corey.
Thank you, Patricia, again for having us and allowing us to shed light. Maternal mental health is here, it's real, it's global, and continuing to have opportunities to, again, awareness, prevention, treatment, I think is invaluable. So thank you very much. And I'm excited to see where this keeps going.
Dr. Saint-Jean, your final thoughts or anything you would like to add?
Patricia, I would thank you again for allowing us to have this conversation, make sure that the awareness is out there. And if I can just leave these lasting sentiments is, let's normalize mental health. Let's reduce the shame and stigma that often goes along with it. Let's allow people to be unwell, say that they're unwell, and be treated, and not have any stigma, shame, or fear, or that it will be weaponized against them. So thank you for allowing us to put forth this awareness.
Dr. Lomo, anything you would like to add for our audience?
And I'd like to echo everyone's sentiments. Thank you so much, Patricia, for this opportunity. This is a global conversation that we're all having at the moment. Perinatal mental health is an important part of healthcare. It's preventative. It's good outcomes for mother, baby, for nation, for the globe. And just to emphasize, I know it's an old saying, but there's absolutely no health without mental health. We should stop separating health, global health care from mental health. We need to incorporate it and give it the attention that it needs. Thank you so much.
Thank you all so much. I spoke today with Lavinia Lumo, Corey Galdon, and Ashanda Saint-Jean. I'm Patricia Vasconcelos, a DC Bureau member of the Association of Foreign Correspondents in the USA, AFPC-USA. This educational program is in partnership with Seleni Institute. Thank you all. See you next time.
Thank you.